sir, we are live.
Okay, that's good. So, good evening to all of you, and very warm welcome on the behalf of IIP Delhi. And this is the, I think, second last session of the eGastro master classes. And we are happy to have Dr. Mohit VOHRA sir, which is National Coordinator for the all presidential action plans also. And happy to have Dr. Narang sir and Dr. Toshniwal sir. And many congratulations to Dr. Meena for concluding this e-Gastro master classes wonderfully. And I welcome you all delegates also. With this, I pass on to Dr. Ajay Gupta sir to say a few words.
Thank you, Dr. Dinesh. Today we are going to have a set Mohit VOHRA and Dr. Toshniwal, who is the president of IIP, and Dr. Gulshan, IIP Punjab. He was the EB member from Punjab also for the Central IIP last year. And Dr. Mohit VOHRA is a national coordinator and renowned gastroenterologist from Jaipur. I request Dr. Shamina to please introduce the speaker. And also request after the introduction, our chairpersons to say a few words.
Hello friends, thank you team IIP Delhi, especially our president Dr. Ajay Kumar Gupta and my colleague Sachiv Secretary Dr. Dinesh and entire OB team as well as executive board members of IIP Delhi. They blindly trust on me and we are successfully conducting series of the academic activities from on the platform of IIP Delhi's. And this year we take the initiation as a gastroenterology field, and definitely in continuation of that we have the third last session 2 days. And for that we have the eminent faculty, dear colleague Dr. Mohit VOHRA. Without wasting the time, I would like to invite Dr. VOHRA to start the talk, because there's the long list for the introduction about the Dr. VOHRA. Is a
Just few comments from the chairpersons.
Is an excellent academician, clinician, as well as philosopher to how to enjoy the life and how to encourage the colleagues, juniors. None of the better than Dr. Mohit. So before starting the colleague, I would like to invite our today chairperson, dear Dr. Pankaj. Hi, Dr. Pankaj, sir. And Dr. Narang, sir. Yeah, Dr. Pankaj. Over to you. Sir, mute. Kindly unmute.
Thanks for inviting, Sachin, and thanks for such a prestigious CMA you are inviting, please. Thanks. And it's a Dr. VOHRA, I know it very well. He's quite a good academician. Please.
Narang, sir.
Good evening to all, and thank you so much for inviting me on this platform. As we all know that hepatitis in children remains a significant and evolving concern in pediatric practice, and ranging from common self-limiting viral infections to life-threatening acute liver failure. So I think today's session will help us and guide us all to strengthen our understanding of its etiologies, clinical approach, and evidence-based management, which is essential for every pediatrician in day-to-day practice. Uh, I welcome Dr. Mohit VOHRA also. Dr. Mohit, we
Yes,
all
sir.
are very eager to listen.
Great, sir. So let me share the screen. Shall I?
Yes,
Sure,
sir.
sure.
Sure, sir. Please start.
So I think at the outset, I would like to thank IIP Delhi, especially the Ajay Gupta sir, Dinesh Goyal sir, and Shamina sir for giving me this opportunity to be among you. And with the permission of the chair, I would like to begin today's topic of discussion. So
Sure,
just
sir.
let
Please go
me
ahead. Please share your
share the screen. Is it visible?
It's still coming. Yes, it's visible. Please make it full screen.
Yeah, I'll do it, sir. Just a second. Is it okay now?
Yes.
Yeah. Great. Thank you.
It's good.
Right. So without wasting much time, let me start straight away with the topic which has been given to me, which is hepatitis in children, a case-based approach. Now, when this topic was given, this itself, when we talk about hepatitis in children, is a huge topic to cover in, say, 30-35 minutes. It's very difficult, especially if you're talking about the case. So how do you define hepatitis? When I say hepatitis, means inflammation of the liver, a pathological condition where liver is inflamed. And if you talk about the etiology, there are various etiologies present, starting from, as Dr. Narang sir said, that from viral to acute liver failure, the wide spectrum. But not only the spectrum, if you look at the causes also, it starts from the infective, metabolic, autoimmune, ischemic, drug-induced. And in infective, it has hepatotropic and non-hepatotropic viral or bacterial or protozoal. There's a long list if you talk about what can cause inflammation in the liver. So what I have decided to cover in these 30-35 minutes, I'll be taking most common, that is one of the viral hepatitis we'll be discussing, and one more topic if the time permits us. It's important to know that in India, hepatitis A is the most common cause of acute viral hepatitis in children. And now India is among the nations where the highest growing burden of viral hepatitis, especially B and C, is also being seen. Now, the hepatitis or the viral hepatitis is the second deadliest communicable disease after tuberculosis all around the world and also in India. So let me start with the very basics of the case, what we have been seeing. So this is a case one. This is an 8-year-old girl who comes to you in your OPD with a jaundice and recurrent vomitings. And prior to that, she had a low-grade fever, anorexia, and a malaise. A typical prodromal history followed by a jaundice and recurrent vomitings definitely starts thinking us that what can be the most common cause of such a condition. When we examine the child, we find that there is jaundice, there is icterus, there is mild hepatomegaly, and no ascites. So when we examine this child up to no ascites, what does that indicate? When I say no ascites, that indicates that there is no involvement of a liver for a longer time, or there are no a chronic liver disease in this. So I am a little relieved because there is no ascites, because ascites is basically a sign of a chronic liver disease where the cirrhosis or a portal hypertension we start expecting. So in such a case, when a child comes to you, no ascites, mild hepatomegaly, jaundice, icterus, we go ahead and get our lab investigations done. Somebody did lab investigations and it came out to be total bilirubin of 8 with a direct of 5.6. You can see OTPTs in the thousands with the albumin marginally, at 3.4, INR 1.3, IgM HAV came positive. Rest of the investigation seems to be normal. USG suggested mild gallbladder edema. So what is the diagnosis? What comes in your mind? What you see in this report is that there is a direct hyperbilirubinemia. What else do you see in this report? That ALT is more than AST. Now, whenever ALT is more than AST, most of the time it suggests ischemia. But what we see, usually the ALT and the AST, they are 10 to 20 times in viral hepatitis. But when they are very high enzymes, especially such in this case, always at your mind, at the back of your mind, have a suspicion that whenever there are very high enzymes, more than 1000 international units per liter, think viral, think ischemic, and or toxin induced hepatitis. The three common conditions what we have is viral, ischemia, or a toxin induced hepatitis when you have a very high enzymes, that is more than 1000 international units per L. Now what happens in your viral hepatitis initially? In the early phase, the prodromal phase, there's a mild or no symptoms and your ALT and your AST starts rising. Bilirubin is usually normal in this early in the prodromal phase. In the icteric phase, which comes after the prodromal phase, that is a peak illness, your ALT and AST, they are markedly elevated. Often I told you that more than 20 times and even can reach to thousands, as in this case. So ALT upon ALT more than AST is an important differentiation it from other disease. What about the bilirubin? Bilirubin starts rising late and persists till late. So let's go ahead. In this case, the diagnosis is very clear since IgM HAV positive, a clear history with a prodromal prodrome, followed by jaundice, followed by vomiting, OTPT increased, your ALT more than AST, IgM HFA positive. This tells you that the diagnosis is acute hepatitis A. And how is that you are going to manage this case? You will manage with a supportive treatment, you will give antiemetics and no dietary restrictions. Now, again, what is very important here is no dietary restrictions. Why do you don't want, why there's a no dietary restrictions I have added into it? That's very important because this is commonly seen in the pediatricians that whenever a child who turns out a viral hepatitis A positive, वो उसको बोलते हैं कि आपको ये नहीं खाना, ये नहीं खाना, ये नहीं खाना, and there's a long list given to that child that not to be eaten. And the diet is made bland, the diet is made less calorie dense. So children already have a poor appetite. They already have a nausea, they already have a vomiting, and restricting diet further, making the child calorie deficit, making him lose his weight more, in again leads to into a vicious cycle, which is important. So adequate nutrition is very essential for the liver regeneration. It's very important because it supports faster recovery. Liver injury in viral hepatitis is self-limiting, but the proper intake of carbohydrates is necessary, especially for energy. The proteins are required for the tissue repair. Proteins are restricted only when you are suspecting the hepatic encephalopathy, otherwise not. So that's a myth that protein worsens liver function. It doesn't spoils the liver function. Rather, protein should be given for the tissue repair. A restriction is only needed in cases of the hepatic encephalopathy. Otherwise, normal protein intake is beneficial. Even the fat restriction is unnecessary. Only if the child feels intolerant, you can ask to avoid a very greasy and a heavy foods in this child. So that's all what we learned from this first case. As I've told you. So let's go on. Moving to the second case. The second case, this is a 10-year-old boy who comes with jaundice, vomitings, and excessive sleepiness. So what has been added to this case? There's excessive sleepiness. And prior to that, he had a low-grade fever, anorexia, and malaise. Look at these two sentences you find. There's a typical prodrome, followed by a jaundice, followed by vomitings, and the child is excessively sleepy. So we go ahead, child has not passed stools for last 5 days. Now, in case of a viral hepatitis, if you are assuming the child is not passing stool for 5 days, does it make you worry? Is it a worrisome sign? Especially if you in a child who is having a viral hepatitis. So on examination, there's icterus, there's mild hepatomegaly, no ascites, but the child looks, a little lethargic, little dull. It's a grade 2 kind of hepatic encephalopathy. Pupil is all right, 3 millimeters reactive. There are no signs of the raised intracranial pressure, but yes, there is asterixis or a flapping tremors which are present. Lab parameters done. It suggests that again, bilirubin of 12 with 8.6 of a direct. Again, AST, ALT in thousands, that is 2400 and 3600 respectively. Albumin has dropped down to 3.2. INR is 2.3. And rest of the findings are normal except for mild ascites, which is seen. So what is your impression? I am still worried about the child has not passed stools for 5 days. Why are you worried when the child has not passed stools? So what is a differential? What is a diagnosis? What is the initial diagnosis I am keeping in mind looking at this child? This is definitely hepatitis A, as IgM HAV is positive. Induced acute liver failure, since INR is 2.3, and we can see that the child is a little lethargic, little dull. He's having a grade 2 and hepatic encephalopathy, and then there is no evidence of raised ICP. If such a child comes to me, I'm worried about the child is not passed stools for 5 days. So why am I worried? Because it's definitely concerning, because constipation means ammonia accumulation. So this ammonia accumulation can precipitate or can worsen hepatic encephalopathy. So that indicates that you have to take care of this child immediately. So how will you manage this, guys? You will give a supportive treatment, you will give lactulose, you will start antibiotics, vitamin K, NG feeding, and still a normal diet. So lactulose again is very important in this child, and it may be given orally. If not tolerant, may be given rectal enema. Again, if not tolerant, even the nasogastric can be given. But we prefer oral and nasogastric method for lactulose in these children. The dose we usually give 1 to 2 ml per kg per dose, and they're given every 4 to 6 hourly. Our target of stools in hepatic encephalopathy or viral hepatitis with hepatic NCEF is 2 to 3 soft stools per day. That's important. If child is not tolerating, then you may give a rectal enema. The lactulose is to be dissolved with a normal saline in a ratio of 1:3, and the dose is around 10 to 20 ml per kg per enema. Again, is to be given 6 to 8 hourly. So the important point, what I just want to tell you, that it has to be a soft stool, should not be a diarrhea, because we may lose electrolyte, or the child may lose electrolyte into it. The target stool is 2 to 3 per day, and that is equal to the optimum ammonia clearance. So, but you need to be very aggressive in your therapy if the child has not passed stools. So outcome is child recovered and discharged. So this was another message that I wanted to give it to you. We move on to the third case, that another child who's 12 years old, again with anorexia, jaundice, vomitings, excessive sleepiness, combativeness, and a later altered sensorium. Now this child has moved into hepatic encephalopathy stage 3 because he's gone into altered sensorium. And besides that, you can see that there is hypertension, there's a pupil which is 6 millimeter, sluggish reactive, there are brisk reflexes, the plantar, bilateral upgoing. So what does it suggest? That there are signs of raised intracranial tension which is there. So why? Why, first of all, there's an increased intracranial tension? That is the question. Why in hepatic encephalopathy? Because we know that this ammonia which has gathered has crossed the blood-brain barrier, has entered the astrocytes, and has caused the swelling of the astrocytes, and the swelling of astrocytes has resulted into cerebral edema, and that is responsible for signs of the raised intracranial tension. So what is the diagnosis? Diagnosis: hepatitis A induced acute liver failure with grade 3 hepatic encephalopathy and raised intracranial tension. How basically is this lactulose working when you give? Now this lactulose converts ammonia into ammonium ions. It acidifies your colon. One ammonia gets converted, ammonium ion doesn't get absorbed. The colon is acidified. So again, the absorption of ammonia is decreased. And also it causes your fecal excretion. So the ammonia is also out of the body. This is how it works. Moving on to the management, that the supportive lactulose, NAC antibiotics, vitamin K, NG feeding, mannitol, 3% saline, mechanical ventilation, and propofol. So now looking at this management, what do you think? 3% saline or mannitol? Number one question. Number two question, what comes to mind, that what is the indication of mechanical ventilation in such cases? When do we basically use the mechanical ventilation? And what if at all is the indication of using N-acetylcysteine? So when initially it was said, but now the literature, now the evidences, now the supports us that N-acetylcysteine is also being used in acute liver failure, especially with hepatic encephalopathy 3 and 4 stages. It has a role where you may start NAC as early as possible. Mannitol and 3% saline, again, there are lots of literature which has been given, but my personal experience and few of the literature that says that 3% saline definitely is better, since it doesn't cause hypovolemia. It rather improves the normal blood pressure. It maintains a normal blood pressure. That is important. It is safer in the renal conditions. It doesn't cause any AKI, whereas mannitol has a risk of AKI since it is a diuretic. The only concern is increased sodium with the 3% normal saline. The effect of 3% hypertonic saline is sustained for a longer time. So that's what important. And ICP, that is the less common bit. So that is the reason why. So this patient was referred to the transplant center with all the transport precautions. Liver transplantation was done, and there was a successful outcome in this case. So again, important message given to the pediatricians, that please refer the patient timely with all the transplant precautions to a specialized center. Whenever you are thinking that the child is in hepatic encephalopathy 3 and 4, that's the time you immediately shift the patient. Don't keep the patient with you. That's important if you do not have a proper transplantation facility at your center. So moving ahead is 6 years old girl. Now this is diagnosed with acute hepatitis A with no liver failure, managed conservatively and discharged. Now this is very common we have been doing in our OPD. But this child comes back again. This child comes back again with a rising bilirubin and a severe pruritus, which is affecting her sleep and her daily activities. What do you think this is? Because the child came to us with hepatitis A, no liver failure, we managed conservatively and discharged her. But now she's coming back with a rising bilirubin. So bilirubin is rising and she has a severe pruritus. So looks like that the child is having a cholestasis, a prolonged cholestasis. So what is the reason for this prolonged cholestasis, which is a very common presentation these days? We have been seeing such cases a lot. So the answer is that intrahepatic cholestasis, which is because of your viral infection, especially commonly it is seen with hepatitis A infection. There is a hepatocellular swelling. There is an inflammation of a bile canaliculi, which causes this intrahepatic cholestasis. Besides that, there is also an immune-mediated injury. Now, this immune-mediated injury is this is basically the host immune response that damages the hepatocytes, that damages the bile canalicular system, and that prolongs your recovery even after the virus clearance. And that is the reason for a prolonged cholestasis. In some cases, we also see the bile transporter dysfunction, which is also responsible for causing the prolonged cholestasis, and also bile stasis. Because of the reduced bile flow, the bile becomes viscous, and that results into stasis, and that results into a typical pruritus which is happening. But in this case, the reason was something else. The PBF suggested of hemolysis and some sickling of RBCs. HPLC was done that suggested that there was a sickle cell trait. Child was managed with UDCA, cholestyramine, fat-soluble vitamins were given, folic acid and adequate hydration, and again the child recovered. So what we have learned from this case is that we must always search for the cause of underlying hemolysis, sorry, in cases of a prolonged cholestasis. Especially keep in your mind, whenever the child returns back with increased bilirubin, with severe pruritus, it may be G6PD deficiency with a male child, a thalassemia intermediate trait, or a sickle cell trait. Look into it and find the cause of, keep in your mind the cause of underlying hemolysis. So I think that's all what I just wanted to convey to you regarding hepatitis A and the basic things what we've been seeing every day. Now moving on to another viral hepatitis, that is hepatitis B. As I told you, that's been increasing now in India, hepatitis B and C. And what is a common scenario which we see? A newborn being delivered with the mother being HBsAg positive. Number one. Number two scenario, we see a 6-year-old child who comes with a prodrome of a viral hepatitis turns out to be a HBsAg positive. Another scenario, a 7-year-old child who is detected HBsAg positive during a preoperative screen. So what should be your approach to all these three conditions, what we commonly now see in our hospitals? So for that, for the answer, you should understand what is the natural history of hepatitis B virus infection. Whenever there is acute infection, it may turn into a chronic infection. And when I say chronic infection, that means cirrhosis, hepatocellular carcinoma, decompensated liver disease, any of these complexities may occur. So 90% chronicity is seen in the neonates and infants. Acute infection, 5 to 10% becomes chronic, 3 to 5% goes to cirrhosis, and 0.01 to 0.03% chronic carriers develop HCC. So these are the complications where this happens. So how do you tackle with the condition at acute infection? How do you tackle the cases with chronic infection? That's what we are going to see. So first is the management of infant born to hepatitis B virus infected mother. Second, we'll be talking about the management of early neonatal hepatitis. Third, we'll be talking about management of acute hepatitis B, and then we'll be learning about the management of a chronic hepatitis B. So perinatal transmission, age of infection, and the risk of chronicity. Now you have to remember this graph. So you can see that if the child is acquiring the infection at a later age, the chances of the chronicity decreases. the baby is acquiring the infection at an earlier age, the chances of chronicity is increased. As I told you in the last slide, that there is 90% of chronicity in neonates and infants who have harbored this hepatitis B infection. So, as the age increases, the chronicity decreases. Now, what are the two markers which are very important in hepatitis B? One is maternal HBsAg and one is maternal HBeAg. That is your infectivity marker. If both the markers are positive, that is mother's HBsAg positive and mother's HBe antigen positive, there is a likelihood of almost 60 to 90% risk of a vertical transmission. But if it is only HBsAg and mother is positive, the risk of transmission to the baby is 5 to 20% only. So, perinatal transmission, active immunization done, all newborn, irrespective of HBsAg status, we immunize our infants with the 3 doses of 10 microgram genetically engineered recombinant vaccine 0-1-6 months. The mother is HBsAg positive, both passive and active immunization to be given as soon as possible. The mother is HBsAg and HBe antigen positive. It is said that more than 10% of neonates are infected despite of immunoglobulins and vaccines. And we have seen the failures especially occurring when the infant is born to HBe antigen positive mothers with a pre-delivery load of hepatitis B more than 6 log to the power 10 copies per ml. So the viral load is very high in the mother, and the mother is HBe antigen positive. Even the immunoglobulins and your vaccine may go failure, and it is almost 10%, more than 10% of neonates being, reported, and that's been taken from the Journal of the Viral Hepatology, 2009. What happened to acute hepatitis infection B and acute liver failure? We have seen that HBV occurs in 10 to 15% of children of acute viral hepatitis in India. Majority of them, how do they present? They present as anictoric or asymptomatic. And most of them, they recover naturally. Symptoms are typical prodromal, that is anorexia, nausea, vomiting, fever. And after that, there's a jaundice with repeated splenomegaly, and the fatigue is intense in cases of hepatitis B. Immune-mediated extrahepatic manifestations may be present, especially keep in mind the macupapular rash and the migratory arthritis or nephritis is seen in older children. Hepatitis B virus-related ALF is uncommon in infants and children. It is associated with more than 40% mortality rate without liver transplantation. So, the treatment of severe acute hepatitis and ALF, the answer is tenofovir, that is your nucleotide analogs which can be used, lamivudine, entecavir. So entecavir, tenofovir, and lamivudine is the answer. There's no role of interferon here in this case. How long you need to give? You need to continue until HBsAg clearance is confirmed or indefinitely in those who undergo a liver transplantation. So when do you call a severe acute hepatitis B? When the coagulopathy or a protracted course for more than 4 weeks and your bilirubin is more than 3 milligram per TL. So very easy to understand and very simple to remember is that in cases of severe acute hepatitis and ALF, you need to give nucleotide analogs which can prevent progression to ALF, the liver transplant or the mortality start as soon as possible. And the commonly which is available is your tenofovir, entecavir, and lamivudine. There's no role of interferon in such cases. So whom, when, and how to treat perinatal transmission? Mother ko you can give the nucleoside and nucleotide analogs. Neonate, you may give HBIG and vaccine. If there is HBV infection, which is acute, if there is a severe acute hepatitis, or there is acute liver failure, you have to give nucleotide analogs. I think it is very simple to understand. If it's a chronic hepatitis B infection, then we'll be talking the treatment separately. So I hope this is clear that if the mother is having a HBV infection, For perinatal transmission, mother is given nucleotide analogs, baby is given HBIG and vaccine. If the baby is having acute infection, acute hepatitis, if it is a severe acute hepatitis, please start with nucleotide analogs. If there's acute liver failure, give early nucleotide analog. They may prevent from going to liver transplant, and there's no role of interferon in such cases. What about chronic? Now, when you define or you discuss the phases of chronic infection of hepatitis B, it has been given into 4 classes. It looks always complex whenever you talk about the phases of chronic infection hepatitis B. The old terminology have changed and the new terminology have become very easy and very clear based on your HBe antigen. If you're HBe antigen positive chronic infection, HBe antigen positive chronic hepatitis, HBe antigen negative chronic infection, and HBe antigen negative chronic hepatitis. And it is HBsAg, HBe antigen, DNA, load, ALT, and liver biopsy classifies them that when and what to be given and such. So I'm not going to details in the classifications. It is just for just to sensitize you that these are the 4 classes which are now being used, and it is try to become quite easy. Just follow the flow chart. The flow chart is again very simple. You have to keep this flow chart under your table. It's quite sometimes difficult to remember all these value, but the major marker which we need to remember is HBe antigen positive. So besides your HBs antigen, now it is HBe antigen which is positive. Always look at the viral load, always look at the ALT and decide how do you need to treat it. I'll repeat it again. One, you have a HBsAg positive child, get HBe antigen done, also get HBV DNA done, and also get ALT done. And based on your 3 values, that is HBe antigen, HBV DNA, and ALT, you will be able to follow the treatment what you need to give. Just depending upon the viral load, if the viral load is less than 2000 or somewhere between 2000 to 20,000 or more than 20,000, you will further decide whether should you perform a liver biopsy or should you want to just keep this child in a follow-up? Would you like to start treatment in cases of moderate or a severe inflammation in case of a liver biopsy or liver fibrosis? So very simple to remember these 3 values. And if in HBe antigen positive individuals, prefer to wait for 1 year for a natural seroconversion. So you may not treat for 1 year if there is a natural seroconversion. Now, what are the guidelines for HBe antigen negative chronic hepatitis B? This was HBe antigen positive hepatitis B. What are the guidelines? Again, what you have to remember here is your HBV DNA and your ALT. And based on that, we're going to decide what am I going to do? Do I need to follow up this child or do I need to perform a liver biopsy and start the treatment? Do I need to rule out other causes? So this is just a flow chart which you need not mug up, keep it under your table. If the patient comes to you, you can definitely well manage this, how you have to approach the chronic hepatitis, whether it is HBe antigen positive or HBe antigen negative, depending upon your HBV DNA count and further your ALT. What are the therapies which are approved in pediatrics in all these hepatitis B cases? So it is lamivudine, tenofovir, which is TDF, more than 2 years of age, tenofovir alafenamide, which is used for more than 12 years of age. This is all important for residents. They have to remember, sometimes they get an exam, the question of, on hepatitis B presentation, what are the classification and what are the drugs which are approved. So lamivudine, tenofovir, disoproxil fumarate, tenofovir, alfenamide. This you get in MCQs, age group specifically being asked, entecavir, interferon, and liver transplant. These are the possibilities what you may give in hepatitis B. So let's go to another, that is the last, the viral hepatitis C, which has also been now gradually, taking load in India. we have seen and has been reported recently. So a newborn who's been delivered to HCV infected mother, this is one scenario. Another scenario is 1-year-old boy, anti-HCV positive, born with HCV infection. What is his future? So 1-year-old boy who's born to a anti-HCV positive mother with HCV infection, and 13-year-old boy, ALL survivor, who was detected with anti-HCV positive. So how do you approach all these three cases? The answer is very simple. How do you detect HCV? It is the documentation of HCV RNA presence in the blood. If HCV RNA is present in the blood, and if that HCV RNA is present for more than 6 months, we call it a chronic infection, and we say that the liver injury is ongoing. What is the fate of hepatitis C virus infection? What we have seen that 25 to 40% of infected infants, they clear the infection themselves. There is a spontaneous resolution of infection which can occur in early infancy. Also in older children, what we have seen, there's a spontaneous resolution, but the rate is a little less. It is 6 to 12%. So spontaneous resolution has been observed in children up to 7 to 8 years of age, but it has been considered that after 3 years of age, this spontaneous resolution declines considerably. So based on that, what we have formulated that the treatment of hepatitis C is to be done in children if they are HCV RNA positive in more than 3 years of age. Those who do not clear the virus, how do they present? They may be asymptomatic, they may have elevated transaminase. Some 12% may develop a bridging fibrosis. Some 1 to 2% may develop cirrhosis. Or very rare and a very few may develop hepatocellular carcinoma and end-stage liver disease. So how basically it affects the quality of life? There may be a developmental delay, there may be a learning disorder, there may be a cognitive deficit, and even the extrahepatic manifestations are quite common in these children. But it doesn't affect growth. That's important to understand. So this HCV RNA, as I said, confirms the diagnosis. How do you screen? You screen by anti-HCV antibody. That's a screening test. And further, you would like to know what genotype, 1, 2, 3, 4. There are 4 genotypes, so you can go for a genotyping. So who needs cure? All children more than 3 years of age with chronic hepatitis C should be treated. As I told you that the spontaneous resolution after 3 years is less. So once you have diagnosed of a chronic hepatitis C, vertical transmission of this virus, baby born to CHC mother, what you have to do? You have to just do HCV RNA at 2 months of age. If it is negative, reconfirm after 3 months. If it is a positive, repeat at 12 months of age and see whether HCV RNA is positive. If HCV RNA is positive, now that child is, is your chronic hepatitis C virus case. Another is your anti-HCV, which is also being done at 18 months of age. If that is positive, you repeat HCV RNA. If HCV RNA is positive, again, that child is categorized into chronic hepatitis C. So now, how to treat if it is positive? It's a very beautiful slide which tells you that initially we talked about hepatitis B. The hepatitis B virus cannot be fully eradicated. Why? Because of this triple C DNA. What is triple C DNA? It's a covalently closed circular DNA which is there in hepatitis B. Whereas in hepatitis C, the virus is entirely cytoplasmic. So hepatitis C can be eradicated from the body, but hepatitis B cannot be fully eradicated. It's going to sustain there always. You cannot cure hepatitis B, but you can definitely cure hepatitis C virus. So what are the drugs? Again, the drugs are interferons plus ribavirin, not going into much details. Again, duration of therapy may vary with genotype 1, 2, 3, 4, as we have discussed. And there's another class of a drug which are useful in, again, hepatitis C, which is direct antiviral agents. Now, these direct antiviral agents, which are commonly used now these days is your Ledipasvir and your Sofosbuvir. All this result into a very good results, and HCV can be eradicated and can be cured if it persists for after 3 years of age. So the revision points, what we have learned in hepatitis B and C, a newborn delivered with mother being HBsAg positive, you have to give vaccine and immunoglobulin. A 6-year child with a prodrome of a viral hepatitis turns out to be HBsAg positive. Early initiation of antiviral, that is potent nucleotide analogs. Interferon has no role, I repeat. 7-year-old child detected HBsAg positive during a pre-op screen. What is to be done? Again, a common scenario. Do LFT, do HBe antigen, do HBV DNA, and treat according to which phase this child is putting into, as we have seen in the flowchart. All these three things are, very important, commonly seen these days on the rise in your hospitals every other day. A newborn delivered to HCV infected mother, what we have learned that HCV RNA to be done at 2 and 12 months, and anti-HCV is done at 18 months, and follow up and treat accordingly. 1-year-old boy with anti-HCV positive born to mother with HCV infection. So what is the future? Again, you have to do HCV RNA and treat accordingly, because this is a curable and a treatable disease. A child who comes to you 13 years, who's old ALL survivor now detected with anti-HCV positive, don't panic. Do HCV RNA positive, treat with a directly acting agents, because this can be cured, this can be treated. Quickly, 2-3 slides regarding a drug-induced hepatitis, which is also very common. It may be hepatocellular, it may be cholestatic. If it is cholestatic, there's increase in ALP, GGT, bilirubin. If it is hepatocellular, there's increase in ALT, AST markedly. And there may also be a mixed pattern. So the most common drug which is resulting into drug-induced hepatitis is the paracetamol. But besides that, actually the paracetamol is a dose dependent. That's what we have been learning. Even in your DNB spots, you get a question lots of time. So in also ATT, anti-epileptics, antibiotics, herbal medicines, complementary alternatives, all these are idiosyncratic type of a drug-induced liver injury. ATT-induced hepatitis, commonly asked, how do you define it? Clinical symptoms present like abdominal pain, vomiting, unexplained fatigue, yellowing of sclera, altered sensorium, plus you have AST, ALT increased to 3 times of the baseline or the upper limit of the normal. You call it that this is ATT-induced hepatitis or drug-induced liver injury. No clinical symptoms, but you have your AST, ALT increased to 5 times of baseline after starting ATT. Then also it has been known as DILI, drug-induced liver injury. Definitely you have to exclude the other causes. So how do you monitor? Baseline LFT should be done before starting ATT. Patient should be counseled about the symptoms of ATT-induced DILI, which is important. There are many guidelines which are being given, whatever is followed in your hospital, whether American Thoracic Society, whether British Thoracic Society or RNTCP, nice guidelines, whatever is being followed, just follow that. But just remember that liver biochemistry based monitoring should be considered at 2-week interval in initial first 2 to 3 months of the therapy in patients, especially what are the risk factors for developing hepatotoxicity. So what are the patients for the risk factors? Risk factors, malnourished children. Risk factors, already having some liver injury, having on some hepatotoxic drugs. So all these are risk factors, and many more comes in this categories. So just do and this is a management of ATT induced ALI. Once your AST, ALT or bilirubin levels are raised, if it is less than 2 times, repeat LFT after 2 weeks. If the levels decrease, repeat LFT as the patient symptoms. If ALT, AST is more than 2 but less than 3 times, you have to monitor LFT weekly for 2 weeks and then 2 weekly until normalization. If your ALT, AST is more than 3 times, then or your bilirubin is more, then you have to stop all medications. Or if your ALT/AST is more than 5 times, regardless of symptoms, stop all medication and consider reintroduction regimen when your LFT is less than twice the normal value. This is a very important flowchart in your private practice, in your as a student in your exams, this is commonly being asked in your Viva everywhere. So ATS re-challenge protocols that after ALT, this is, I'm talking about the American Thoracic Society. So after ALT is less than 2 times, you may introduce rifampicin followed by ethambutol. After 3 to 7 days, INH may be reintroduced, subsequently rechecking ALT. If symptoms recur or ALT increases, the last drug added should be stopped. This is a dictum. And paracetamide, which is known for hepatotoxicity, should not be reintroduced, or if at all, introduced in milder cases of hepatotoxicity. This is another given by the British Thoracic Society, that after ALT returns to less than 2, you start INH at a low dose, then increase to full dose at day 4, introduce rifampicin at day 8, and increase to full dose at day 11. Paracetamide to be introduced at day 15, increase to full dose at day 18. So there are two various different reintroducing protocols being given. Follow whatever has been given to you. So the revision points regarding this, that ATD induced DILI difficult to avoid, but you have to predict and diagnose. Educate patients about drug-induced liver injury, baseline LFT before starting ATD has to be done. Serial LFT monitoring, as I told you, every 2 weeks, especially in high-risk cases. High index of suspicion is must, that is by diagnosis of exclusion. Immediately withdraw ATD once the criteria fulfilled more than 3 times, with symptoms more than 5 times, regardless of symptoms. And reintroduction of first-line drug once only your ALT is less than 2 times upper limit. Sequential versus incremental, as it is given. So I think that's all what I can cover in these, little 35, 40 minutes what have been allotted to me. So thank you so much for the patience listening. And any question, I'm there.
Thank you, dear Dr.
Thank you, Dr. Mohit,
for
for
this
a
such.
wonderful
Sir,
presentation.
I'm not able to hear you. Can you speak a little loud?
Yeah, Dr.
Should I
Dinesh.
stop sharing?
Yes, yes.
Yes, sir. I hope it was not a bouncer, especially,
No,
hepatitis
Very
B
simplified.
and C is a little complicated, but I tried to make it as easier as possible.
Actually, our main audience is the residents and private practitioners. So it was very comfortable
Okay,
for them.
great.
It's a very good presentation, and it really enhanced our perception about hepatitis B vaccines and our hepatitis B management.
Thank you, sir.
It's a very good consideration. And one thing I want to add, hepatitis A has a very rare side complication, that is the aplastic anemia. I have seen the 2 patients who develop aplastic anemia after hepatitis A infection.
Yes, it is definitely. But 2 patients you've seen, that's great. But definitely, as I told you, that
Yeah.
patient, especially in the cholestatic phase, also, you have to keep in mind the sickle cell trait and aplastic anemia, not that common, but yes,
Yeah, it's a
one of a
very
rare,
rare case.
rare complication which may occur. Definitely, all these rare possibilities you need to keep in mind with all these common infections going on. Absolutely true.
Dr. Mohit, before we begin the discussions, now a hepatitis E vaccine has become available.
Yes, very true. A and E, they are rampantly increasing, but at the same time, surprising is that if you look at the figures which has been released last year, we could see that there's a rise in 10 to 15% of hepatitis B and hepatitis C in Indian children. So that is a major concern, because we know that hepatitis B and C are not a fecal-oral transmission. So how children are getting this much is again a part of a neglect which has to be, surfaced, and of course the treatment has to be well versed to treat such cases.
So any
Yes, nice.
recommendations have come from IAP about the hepatitis E vaccine use?
So I'm not getting this voice, sir.
Any recommendations have come from IAP about the hepatitis E vaccine use?
No recommendations has yet been, released by IAP. They're yet to release they are giving some guidelines, what they are giving. Even STG guidelines were given of viral hepatitis last year, but it is not, very beautifully covered hepatitis E. It's basically relying on hepatitis A only, and they've mentioned about on B and C. So just a line about hepatitis E. I think still we need to work more in this because hepatitis E incidence definitely is increased, but still, if you talk about the adults, if you talk about the pregnant women, you can see hepatitis E as one of the major culprits in them as viral hepatitis.
Dr. Mohit, it was a very informative talk for the all the residents. But just the most important point, what I feel, is the best time when to refer. Just this is the most important point. Second is, I think, fair to refer.
Absolutely.
So, can you give us some information that from our area, from in Punjab mostly, I think there is no center for liver transplant or that type of care.
So, sir,
Third point,
Punjab,
what I want to know
yeah.
is average cost for if liver transplant is required. The first question by the parents is whenever we talk about that this patient is in failure and we have to refer the patient may need transplant. The first query is खर्चा कितना
What's
होगा
the cost?
कहाँ
Right.
जाएं
Right, right. So now I think we are lucky to have lots of centers in India, starting from Chennai, Pune, Lucknow, Delhi, Mumbai, all these metro cities. They have developed not one but multiple centers which are doing liver transplant, and even we can see that there are centers who've been claiming that they are doing 100 liver transplants per year. What I was just seeing, even the Rela and the Pune have come up with a good number of liver transplants. Even Medanta is around doing 40, 50 transplants in per year. So an average expenditure when I did my fellowship in pediatric gastroenterology from Medanta, what we could see was ranging from around, say, 18, 20 lakhs, at least starting from minimum. It may depend upon the complication where it is. But yes, definitely, there are centers who are doing it even for 12 and 15 lakhs and 18 lakhs, provided that the patient and the attendants, they have some below poverty line documents to suggest, and they are able to, raise the sources, raise the amount for them for which they've been getting this from the social network. That is again there to help them. So that is one thing which definitely can help, because we at Medanta have done a lot with the rickshaw wala's son, and that was done at a very, very meager amount. So that again
Okay.
depends upon your social background, and if you have a documents to support, definitely some amount can be raised from the societies who are ready to help, and we can do it. Now, sir, it is, since Punjab is such a big area, you have to, see from Jalandhar, from Amritsar, from Ludhiana, and from Patiala, where and which is the nearest liver transplant center. Because what I have learned till now in my pediatric gastroenterology, that whenever the child is in a hepatic encephalopathy, if it is started, don't keep with you until unless you have a liver transplant center. Don't think that I am going to cure this child, I am going to bring him out from the liver failure, and this will happen, that will happen. I've started NAC, started giving lactulose, I'm giving so many things which are available on the earth. No, no. It's always better to shift this child as soon as possible before, because what we have seen in my experience, many children coming, they are brain dead because of cerebral edema.
Mhm.
So herniation has occurred. So that should not occur. That should not, we should not miss that chance when we have that facility in India. That's
So
the
that means referring point is whenever encephalopathy sets in, whenever you
exactly,
suspect encephalopathy.
exactly. Whenever encephalopathy, that's a very critical point. That's the right time that you start referring the patient to a liver transplant. Because now he's very, in a condition which is, he might go this and he might turn this side.
That's a turning point basically.
Exactly. That's the reason.
Hmm.
Thank you, Dr. Mohit, for a wonderful case-based discussion.
Thank you, sir.
Before further discussion, I would like to take the few questions from our audience. Does any particular type of the antibiotic suggestion those are the children suffered with the acute hepatitis?
Sorry?
Does any particular recommendation about the antibiotic those who children suffered with acute hepatitis?
Does any antibiotic causing hepatitis?
Any antibiotic recommendation? Does any particular antibiotic recommendation for the children suffering with acute hepatitis?
No, no. Usually, we know that what is the cause of hepatitis. If you are fully aware that this is a viral hepatitis, we say that antibiotic has a no role, but why do we need antibiotic? Because to combat the complications, the secondary complications, which we assume may occur in these children. And the answer is a broad spectrum antibiotic, because it's not for the viral hepatitis you are giving.
So in the short, those are the children have the classical prodrome symptoms, not required any
No
antibiotic.
antibiotics at all.
But if the child have the prodrome, but fever is going on beyond the 5 to 7 days, then definitely we are the dealing
Sir,
something
if the fever is
along
going
that
on
viral
beyond
hepatitis.
jaundice, then you
So,
should look for the complications. It
so
may
that,
be liver abscess, it may be typhoid, it may be dengue, it may be something else. So
so
the scrub typhus. So that all complications, all other associated diseases you need to because once the fever goes down, the jaundice sets in. If there is a jaundice and the fever persists, आपके कान खड़े हो जाने चाहिए कि there must be something else which is going on. So maybe it is a coexisting infection which is occurring, or maybe it's a liver abscess or something else which is being developing in this child.
So for the message is very clear for the pediatrician. If the child has the classical prodrome symptoms, here I would like to highlight the prodrome symptoms is not classically seen below 5 years. But usually as described the literature, child have the malaise, decreased oral intake in the form of anorexia, non-specific pain abdomen, nausea, vomiting, followed by the fever. Then fever persists for 2-3 days, just like the not very high grade 100, 101, 102. Then subsequently appear the jaundice. That we are rightly handling the case of hepatotropic virus infection, either hepatitis A or hepatitis B. In that situation, not required any antibiotic. But
Not
if
at all.
if the fever persists beyond the 5 to 7 days,
Then evaluate. Then
then in
evaluate.
that situation, we might be get the child have the hepatitis A along with concurrent infection in the form of other tropical infection, then might be antibiotic might be required. Then the other audience asking what is the liver transplant in the Chandigarh and what is the cost. So I did my DM from the Chandigarh that right now in the pediatric they have the selective liver transplant in the Chandigarh. But yeah, cost is very variable as Dr. Mohit rightly said. If you are come through the corporate social responsibility or like the charity fund, it might be get the two economic liver transplantation. But yeah, average cost is 15 to 20 lakh minimum cost, that is for the liver transplantation. Subsequently 4 to 5 lakh for the subsequent chemotherapy or subsequent post transplantation care. Dr. Mohit, your first case, you said that 8-year child have the classical prodrome followed by the jaundice. So here the message is very clear cut for the pediatrician. Don't forget about the inquiry of the prodrome symptoms, because that is very important. If you get the classical prodrome symptoms, you might be not require the too much investigations. So first in the history you try to get the prodrome symptom. That is very important thing. And second thing, if the child come after 7 to 10 days later on, you might be not get the transaminitis such your expectation like the 10 times, 20 times, 30 times. In that situation, you should might we get the clue by the previous history of the prodrome. So that's why history is very important. Then the one of the audience asking the what is the expected time to settle down the jaundice or bilirubin in the classical acute viral hepatitis, especially I am talking hepatitis A.
6 to 8 weeks.
So that is a literature say that the widely variable, but yeah, sometime maybe 16 week, but 8 to 12 week is usual time. मतलब usually 3 month में settle हो जाता
Yeah,
है.
it may persist for 3 months, but 6 to 8 weeks is a proper time.
But
And
if that jaundice person beyond that, then you should inquire the history for desi dawa, chem intake. That is very important thing in the or India's. There's a lot of the patients come through the babas or lot of the Ayurvedic medicine or some of the kadas. So don't forget to about the inquiring that. That is very important thing, and that is a main culprit to suspecting the underlying chronic liver disease. Even the child have the classical prodrome, but persistent of jaundice, that is might be caused the
also
unnecessary
keep in mind cholestatic jaundice, also keep in mind relapsing jaundice, also keep in mind recurring jaundice.
So other things, when we suspect the relapsing hepatitis A,
When you were absolutely all right, prodromal all features, clinical features, they have gone back, your bilirubin has come down, and after say a week time, again there's a repeat jaundice which occurs to a child, then bilirubin starts increasing, you have a transaminitis. That's what is a relapsing jaundice which occurs.
So in the relapsing hepatitis, before labeling that is solely due to the hepatitis A, we should take the proper history, because sometime maybe have the underlying autoimmune liver disease, maybe sometime may have the progressive familial one of the milder variant like the BRICS. Then usually child have the classical history of prodrome followed by the transaminitis, then settle down that enzymes near come down the near normal range for that persist 2 to 4 weeks, then subsequently again rising to start rising trend of the transaminitis. That is a second episode. So that is in that situation we can say like child have the relapsing hepatitis A. That is very important thing. And you in the your second case and third case, you rightly said the CNS complications like the encephalopathy, constipation, these are the common thing. So for the pediatrician, clear cut message: any child have the hepatitis, you must be prescribed the laxative, especially for first to second week of life. That is very important thing. Try to avoid the unnecessary constipation that might be triggered for the encephalopathy. That is very important. And especially for the और pediatrician, डॉक्टर नारंग rightly highlighted, भाई हमें तो सिंपल सा ये बता दो किस बच्चे को हमें रखना है, किस बच्चे को ट्रांसप्लांट या whatever gastroenterologist के पास भेजना. सर दैट इज अ वेरी क्लियर कट. इफ clinically any child have the CNS involvement, that might be that child worsen, better to refer the child to at least tertiary care hospitals or liver transplant center. But if the child, like in the today's you examine the child have the significant hepatomegaly and next day liver is totally not palpable, that means that child have the significant acute hepatocyte loss, that might be that child subsequently deteriorate. So better if the clinically disappear the liver suddenly, rapidly, even enzymes suddenly 2 days before that child have the 5,000 enzyme and now the child have the just like the 200, 400. That indicate the massive loss of the hepatocyte. Better to refer the child to heart center. For the postgraduate benefit, some of the subtle markers like if the child have the high lactate, if the child have the low uric acid, these are the subtle markers that might be give the clue that child have the some significant issue in the aspect of liver failure. So these are the tests on the bedside we can get the indirect clue for the that child might be have the some worsening for the next 2 to 3 hours. Then usually for the pediatrician, any child have the viral hepatitis with the INR is 3 to 4, that with or without CNS involvement, better to refer the child for at least tertiary care, good setup of the ICU. That might be because CNS once it started to involve, that child rapidly worsen. Don't say like that child still have the stage 2, might be take the time for shifting to stage 4. That rapidly deteriorate. The Dr. Mohit already said one of the cases the CNS herniation or like that thing. So you should take the very carefully and handle that cases in better setup rather than the allied setup. And one of the important thing for the pediatrician, any hepatitis child, if the bilirubin in the double digit, if the hemoglobin in the single digit, always think for the hemolysis. That might be due to the G6PD as intravascular hemolysis. If you are thinking G6PD, then child have the intravascular hemolysis. In that situation, splenomegaly not present. But if you are thinking the autoimmune induced hemolysis, then might be extravascular hemolysis, then spleen may or may not be palpable. But in that situation, you try to avoid the vitamin K, because majority of kids I'm working in the tertiary care hospital, many times children have the worsening of the jaundice after getting some IV injection. That likely maybe especially in the Punjab region, that the G6PD is not uncommon in India, especially in North India. That we should be must be thinking and include in your history like the cola color urine. That is very important surrogate marker for the intravascular hemolysis. That is important thing. So before giving the or prescribing the repetitive vitamin K, if hemoglobin falling trend or jaundice in double digit like the 10, 20, 15, usually not seen in the hepatitis A, can be seen but usually not seen. In that situation, you should take more carefully about the vitamin K or other thing. That is very important thing. And about the hepatitis C, Dr. Narang said, what about the vaccines? Sir, hepatitis E infection is also one of the challenging issue in the Indian scenario where the fecal-oral transplantation is not unusual. It is quite common. But till date, as literature says, the hepatitis E vaccine first launched in China in 2011. But in the India, in the opening of the 2026 launch, one of the pharmaceutical company that launched, that I'm not aware about the cost, but that launched for the 18 to 65 year age group, not for the pediatric age group. And we remember that still USA is not launched this hepatitis E vaccine in the America. Yeah, definitely there the fecal-oral route transmission is not a problem their side, but in the developing country, that is a very important issue that might be in future we get the approval for the pediatrics, but nowadays that only allowed for the 18 to 65 year of age group. That's okay.
Thank you, Dr. Meena, for the clarification.
Okay, thank you.
I
Yeah,
have one question if you have 1 or 2 minutes. Yeah.
yeah, yes.
Yeah, we have one patient, like lots of usual essay. Which anti-epileptic is safest for hepatic encephalopathy when they have throat seizures? Like majority of the anti-epileptic, we say, oh my God, they are hepatotoxic. They go for the metabolism in liver. So which is the safest anti-epileptic? And suppose we begged, okay, you can take away the child, it is encephalopathy settled, but majority of the patient they refuse कि ठीक है हमने आपको दे दिया बचेगा ठीक है नहीं बचेगा भगवान का तो हमने रखा है अभी भी हमारे पास 2 पेशेंट आईसीयू में दे हैव रिकवर्ड बट द प्रॉब्लम इज अगेन सेडेशन की मिडाजल हम नहीं देना फेंटा प्रोपोफोल इज हाइपोटेंसिव चाइल्ड इज malnourished को you can say super added bacterial infection was there. Now that patient is improved, but again the waxing waning, is there any role of repeat NAC when the patient is recovered but still we my resident कि मैडम पहले लगाया था बड़ा जल्दी रिस्पांस आ गया था अभी फिर ये थोड़ा वैक्सिंग वैनिंग हो रहा है should we try? So I was kind of let me search the literature or ask the expert opinion.
First of one thing, I would like to take the call for the anti-epileptic drug. Ma'am, in the likely seizure in hepatitis infection likely due to the metabolic derangement, so might be not require the long-term anti-epileptic, but it better to give the levetiracetam rather than anti-epileptic like the Epton or phenobarbital or like the valproate.
So levetiracetam is a drug of choice.
Drug of choice is better to prescribe. But if you are talking about some of the short-acting benzodiazepines, as much as possible, try to avoid. That is a literature said, and that is as a gastroenterologist or hepatologist we can say try to avoid. But you feel you just give the short-acting benzodiazepine as lower mod dose toward the safer side.
Okay. But still, I think levetiracetam is a drug of choice because the minimum hepatic metabolism.
Dose we reached maximum, and then one day she had toning. We were already giving 40 to 60 milligram per kg per day.
Yeah, and
then again one day she had. Then we were stuck कि अब क्या करें तो हमने literature वगैरह search किया सब ये नहीं देना वो नहीं देना तो pyrametic लगा but मुझे I was not very confident कि okay levetiracetam we have used till the maximum dose. Child is with us now, she is improved. Encephalopathy.
If needed, phenytoin can be used, but with a caution. If needed. Okay. Second drug, what you can, because there's a hepatic metabolism, but still another drug, because valproate is absolutely contraindicated. First is levetiracetam, and if at all to be used with caution, you may use a phenytoin. That's important.
Any repeat doses of NAC we can use?
100 milligram per kg per hour is the infusion what we
no repeat second like child is
I'm coming on your question, ma'am. Till the available literatures, there's a very clear cut indication about the N-acetylcysteine, either injectable, either oral, that the genesis started from the paracetamol poisoning. That is a clear cut. And then developing countries still saying that the N-acetylcysteine role only paracetamol related poisoning. But if you look the literature from the developing countries side, and one of the best study we frequently quoted in the Lee et al., they said that the N-acetylcysteine definitively role in the drug-induced hepatitis, but especially paracetamol, but other associated like the chem intake or other unknown substance associated liver injury that might be give the help. We have the not clear cut evidence, but they give the some of the hypothesis because N-acetylcysteine have the 3-4 mechanism is more help to stabilizer like the inotropic actions, immunomodulator, and one of the important thing, antioxidant. These are the 3-4 mechanisms that help to restore the liver for the normal metabolism. That the once you start the N-acetylcysteine, maximum duration is 5 to 7 days. After that, literature says then no role, but you can extend up to the 5 days once you start. But after 5 days, no any we have the evidence to repeat the dose for the any type of the etiology.
The 2-3
Thank you.
questions. What I can see that what age is the cholestyramine can be given. So usually given after 1 year of age, and not below 1 year of age we prefer, because again it is given at the 240 milligram per kg per day in divided dosages. It may cause the fat soluble vitamin deficiency, so you need to take care of that. Another question is, what is the ratio of AST ALT? AST ALT ratio more than 1, as we've been seeing, is basically in the alcoholic, more than 2 is seen in your alcoholic liver disease. AST ALT is seen in cirrhosis, so that's a ratio. ALT is more specific for liver, that's what you should remember. And whenever AST ALT is more than 1, more than 2, think of alcoholic liver disease or cirrhosis which sets in. That's important.
So I think Dr. Mohit here, I want to asking about the drug induced aspect. So if the ALP oblique ALT oblique ALP ratio is more than 5, that indicate the hepatocyte oriented drug induced liver injury. If the ALT oblique ALP ratio is more than 2, that indicate that injury likely cholangiocyte oriented, and the between that ratio that indicate the mixed type of the injury.
Exactly. So
On
that's
the
what
basis of
I
that
didn't
we
go
can
into the detail of it, but what I had given just the highlight ki it's a hepatic, mixed, and the cholestatic type.
thank
So
you.
एक question है कि भाई when should be the hepatitis C the baby who's been born to hepatitis C mother, when should be screened? Should be screened at a 2 to 3 months of age. That's a perfect time for, as I told you in the flow chart, right?
Sir, I just want to the last message to our pediatrician before labeling positive even hepatitis A, B, C. First, make sure कि test proper kit or proper lab से हुआ. Don't quote the rapid car test. Before taking any important decision, you must be sure that first, like the HBS or whatever, that should be through the proper methodology, because we are taking the important